morning, everyone. Thank you for being here for today's webinar. We have a really special guest with us today. We have Karen Howard, who's here from Mental Health America, who, if you're not familiar with Mental Health America, they are our parent organization, if you will, and Mental Health Association in Michigan is more of the state affiliate or chapter. So we're so lucky to have Karen with us today because she's going to talk about all things public policy at the national level. So Karen Howard, she currently serves as Director of Policy and Advocacy for Mental Health America and has 14 years experience in legislative and political affairs and advocacy. Howard advises and carries out the policy and advocacy strategy for a national community-based consumer nonprofit organization whose mission is to put the voices of people with lived experience of mental health conditions at the helm of decision-making, both at the policy table and in healthcare settings. She educates and persuades federal and state policymakers to act on a wide range of issues that impact individuals with mental health conditions, including healthcare, education, criminal justice, and housing. And she facilitates relationship between state and local MHA affiliates like us and their federal and state public officials. Welcome, Karen.
Thank you so much, Kristen. Hi, everyone. I'm Karen Howard. Really nice to be here with you.
Thank you, Karen, for being with us today. Hi, everybody. Thank you for being here. Mary Ann Huff, I'm the president and CEO of the Mental Health Association in Michigan. And as Kristen mentioned, we are an affiliate of Mental Health America, and we've been an affiliate of Mental Health America since 1936. So we've been around for a while. Given everything that's occurring at the federal level, particularly of interest to us, we're focusing a lot on the Medicaid, the proposed Medicaid cuts at the federal level. I thought it would be wonderful to have Karen Howard here with us today to talk about that, because that is her area of expertise. So that's what we're going to do today. We're going to focus on that, talk a little bit about parity, and a little bit about HHS, but because you might have questions, you can put those in the chat, and we'll make sure that we reserve about 15 to 20 minutes at the end for questions so that Karen can answer those for you. So again, thanks for being with us today. And Karen, I guess, where are things today?
Sure. Thanks so much, Marian. So I'll just start by giving a bit of a high level overview of how important Medicaid is to mental health and behavioral health, and then go into reconciliation. So you all might be aware, but I'm happy to kind of share resources as well so that you can reference this information in the future in conversations. But Medicaid covers approximately 26% of all mental health treatment costs across the country and 40% of addiction costs. So nearly 40% of the non-elderly adult Medicaid population has a mental health or substance use condition. And most of that population qualifies for Medicaid because of their income status. Medicaid expansion as part of the Affordable Care Act allowed individuals without dependents with income levels up to 138% of the federal poverty level to be covered by Medicaid. So that's around $18,000 to $22,000 annually. And some of these people might be working part-time, full-time, but unable to really purchase their own health care or are not offered it through their employer. And 41 states, including Washington, D.C., expanded Medicaid. 10 states did not expand Medicaid. And of the 41 states that expanded, 14 states have automatic trigger laws for federal matching changes. So that really means that should the federal matching rate of 90% be changed for throughout this budget reconciliation process, those 14 states would automatically cease to cover the expanded populations. it would trigger kind of a reversal of the expansion policies in those states. So we know that Medicaid is the #1 payer of mental health and substance use services across the nation. And that really a cut to Medicaid is a cut to behavioral health. Um, I can go into now, if there are no questions about that, really where we are in the budget reconciliation process federally. So currently, the Congress has been tasked with, extending the president's tax bill from 2017. To do so, it will have to find savings from other areas of the budget. The Energy and Commerce Committee is the committee with jurisdiction over most health spending. The Ways and Means Committee in the House also does too. But that is a much smaller share of Medicaid and Medicare. The Energy and Commerce Committee really is the main committee, and it's the Nonpartisan Congressional Budget Office came out saying that even if Energy and Commerce Committee has over $500 billion in of kind of budget authority in Medicare, Social Security, and Medicaid. In the budget reconciliation package, which is a type of bill that is able to be fast-tracked and pass much faster, it was used to, for instance, previously enact the Affordable Care Act. It requires just a simple majority vote in the House and Senate. In the House, it's typical for legislation to pass with a majority. However, in the Senate, there is a requirement that a bill is able to get through a filibuster, and that requires 60 votes to invoke cloture. And that means that basically the chamber will go ahead and move forward on that legislation, which means that, you give more power to the minority in the Senate, and Democrats would have to side with Republicans to pass any bill that wasn't reconciliation. However, a reconciliation bill in the Senate can pass with just 51 votes. And anything in that bill has to just be germane to the budget spending or revenues. That is the main difference between a budget reconciliation bill and any other typical legislation. The current budget reconciliation bill was required to find over $4 trillion in savings from different places and to advance these kind of tax cuts. And the Energy and Commerce Committee's jurisdiction, the language in the budget resolution, which is the first step to pass reconciliation, you have a top line number that both chambers agree to, and then language that each of the committees are assigned. The Energy and Commerce Committee was assigned to find $880 billion in cuts or savings from their budget. The Nonpartisan Congressional Budget Office came out to say that even if you cut all of the rest of the kind of spending in the Energy and Commerce Committee's jurisdiction, you would still have to find over $350 billion in cuts to Medicaid. So we know that while there are kind of narratives or arguments that Medicaid was not mentioned at all in the budget reconciliation bill, we know that the cuts will come, they have to come from Medicaid. This would be the current bill that is being considered. It passed through the Budget Committee on Sunday after a first failed vote on Friday. It did pass through the Energy and Commerce Committee last week, and that's the bill that passed through the Budget Committee this Sunday, and then is now a couple of tweaks have been made as there have been kind of arguments from hardline conservatives that the bill isn't cutting enough. And there are also arguments from moderate Republicans that it's going too far. So there have been some kind of changes, minor, to the bill, and the Rules Committee will mark it up at 1 a.m. tomorrow, Wednesday. There is a markup scheduled for 1 a.m. so that the bill can really meet the deadline of being passed before the Memorial Day recess, which was what kind of the speaker had promised the president. Typically, Congress is not meeting at 1 a.m. The bill finding $880 billion from the Energy and Commerce Committee's jurisdiction means it will be the largest cut in history to Medicaid. We will go back in time decades. The current bill, which I'm happy to share the section by section summary from the version that passed the House Energy and Commerce Committee. This goes through each of the sections and what they do. It's provided by Families USA, thankfully. Most of the savings are generated from work requirements imposed on the Medicaid expansion enrollees, more frequent eligibility checks, and limiting taxes states levy on providers to help fund Medicaid expenditures. The work requirements do have exemptions for people with a disabling mental disorder and a person with addiction. However, there's more I'll go into there, as we've seen any state that implements work requirements does so with a lot of errors, technical and administrative, that really kick people off of their plans unnecessarily and inappropriately. This legislation before us now also requires enrollees that earn at least 100% of the federal poverty level to pay cost sharing going forward. That $35 would be for specialty care. However, thankfully, some of the conversations it seems that we've been having have paid off. There is an exemption to that cost sharing for people with mental health and substance use disorders. Additionally, within the bill, several rules are delayed from being implemented that had passed under the Biden administration or that had been proposed and finalized under the Biden administration, including one that would have made it easier for mothers and families to maintain coverage across health plans. In addition to what's currently in the budget reconciliation bill, there are other expiring tax subsidies that allow working people to buy their own private insurance in the health market. Those subsidies are expiring. And the Nonpartisan Congressional Budget Office estimates that with the cuts in the bill and these expiring subsidies, over the next several years, more than 13 million people will lose health coverage. Excuse me. We also have, while we've seen Democratic governors band together to really denounce Medicaid cuts and really invoke the budget problem that these federal funding cuts would impose on states, we've actually seen Republican governors go ahead and start signing bills into law requiring work reporting. This includes Idaho, Iowa, Indiana. Ohio has also submitted an application to CMS for work requirements. So we see a very kind of political divide along these work requirements, but there are some moderates in Congress that have signaled they're not willing to vote in favor of cutting beyond a certain amount. So we're really strategizing to have conversations and outreach from constituents in those members' districts. Unfortunately, Michigan is not one of them. In Michigan, we have pretty much are of the understanding that the congressional representatives are where they are and they're not moving. So the work requirements, more specifically, impose a either monthly or weekly check-in. However, what we know is that there have been a lot of failures and errors in implementing these requirements. So Deloitte is actually the contractor across most states that have been responsible for building systems that will kind of determine folks' eligibility and allow them to check in and submit their work or community engagement hours. And right now they're being sued by the National Health Law Program for ongoing and nationwide errors and unfair and deceptive trade practices that are taking years to fix and have resulted in many people losing coverage. You might remember in 2018 when Arkansas first implemented work requirements. Over 40,000 people lost coverage within the first kind of week or so, and a judge actually put a stop to that policy as people were losing coverage not because they were ineligible or intentionally like not submitting their requirements. They were losing it because the system was bad. Consumers were not getting information about how they're supposed to submit their hours. There were kind of systemic errors that locked people out of the system that they were supposed to be reporting to, and all of that was really outside of the consumer's control. In Georgia, more recently, a person who was really the poster story for work requirements lost his coverage twice and is now really railing against work requirements and the program in Georgia. So we're seeing people who were once, proponents of this policy come out against it and, really recognizing that it's just not working. It doesn't work. And I want to note that there's a study done, and I'll try to grab the link for you. It came out this month earlier in JAMA, the Journal for American Medicine. It showed that when states started to unwind and allow people to kind of be redetermined, their eligibility to be redetermined after the public health emergency ended, the people who lost Medicaid coverage more often than not had anxiety, depression, and worrying disorders, as well as memory issues. So we see that there are special challenges for our population to meet certain requirements. Even if they are eligible for coverage, they may not be able to kind of follow some of the protocols on their own without assistance. And the states are not providing the assistance that people are needing to keep their coverage. We know that people who lose coverage oftentimes are unable to stay well, pay for their care, and can end up being criminalized. And this puts more pressure on our public safety system versus ensuring that a person is getting a mental health response to a mental health problem. And
I have a question.
sure.
Go ahead. I have a question for you. So the work requirements, they're looking at those that only pertains to Medicaid expansion. Does that apply to any other type of Medicaid?
No, currently it
Okay.
is only for Medicaid expansion enrollees, so those making between 100% and 138% of the federal poverty level
Okay, thank you.
without dependents. I did see a hand up. Yeah, Margaret?
Yeah, sorry. the problem, I mean, I've worked with some of the refugees and they're not literate anyway. They're not, there's literacy is a huge issue. And when I was even helping them, it's even complicated for me and I work in the system. And so it just seems like all they're doing, and I know I'm complaining, but all they're doing is actually increasing the systems that have to keep checks and balances and, the administrative aspect of it. I mean, I don't know whether we could hit them on, we need a one insurance for everybody and then go from there because it's so much more expensive. I mean, I don't know. I don't know. Thank you for letting me rant a little bit, but it is difficult, those systems.
Absolutely. And in MHA's statement last week on the bill, we did actually say that really sets up bureaucratic barriers to getting care easily. So the we try to hone in on the fact that here's the statement. We try to hone in on the fact that yes, this is just setting up bureaucracy and administrative hoops that people have to jump through unnecessarily. Um, and we also, will continue to kind of bring that sentiment to congressional offices, especially in those moderate districts in Arizona, California, New York, where we have Republicans who are not comfortable with the size of the cuts because they're in Democratic or states, or they've, only won their elections by a slim, slim margin. In fact, there's polling from several sources, but including a longtime Trump pollster, that shows um, cuts to Medicaid are deeply unpopular and opposed by Republicans. Um, Let me see if I can. Yeah, here's the firm is the Tony Fabrizio firm. They've done long time kind of polling for Trump, and it's very clear that the voters are not in favor of cuts to Medicaid and really value Medicaid as an entitlement program. They are okay with cutting drug costs or other things for savings, but it's pretty clear that, there's an undervaluing, I think, of voter opinion right now, and even a sense that maybe falsely that members who vote for this legislation will be safe. Certainly, if vote turns out, there will be folks voting them out of office. However, we're not in an election year, and so they will have some time left. I also want to note that, it seems that many conservatives are not concerned with polling or voters, and they might be falling back on the idea that there's legislation to suppress voting. So the SAVE Act was introduced and moved forward in the House. And it creates barriers to voting for married women and other US citizens and residents. And, by suppressing vote, you could potentially keep yourself in office. There are also voter IDs popping up in the states, and other ways to make it more difficult for people to really express their civic duty.
Karen, I have a question regarding Medicaid because, Michigan, we're a unique state because we closed a lot of state psychiatric hospitals in the 80s and the 90s, and right now we only have 4. And in 2004, we got the 1915C, the B waiver for our public mental health system, and a lot of individuals with serious mental health conditions were able to basically have successful lives in the community because of those what we now call long-term supports and services. Do you think that those who are making these decisions about Medicaid understand all the different ways that Medicaid is used by states to keep people with more significant behavioral health conditions out of institutions and in the community, or what we would call the least restrictive setting? Do you think they understand that?
I think that some people do understand that and simply do not care. And I think that there is, as we saw in many of the town halls earlier this year, a a shielding from reality and the truth. And unfortunately, while we are continuing to pound the pavement, I don't know that the stories of people who are benefiting from uh, the long-term services and supports, the home and community-based services, and these other, kind of really supportive services are outweighing. I don't think their stories are outweighing this political goal of ensuring that the president is happy with his tax bill. I do think that elevating these stories, though, with congressional offices will continue to be important. So I know, Marion, you sent a great letter to all of the Michigan delegation. I think finding the stories of individuals who are benefiting and really uplifting those testimonials can go a long way in
Okay.
educating members about the benefits that they're having from Medicaid that allow them to work or stay engaged in community.
Yeah, because one of the things I've tried to express to legislators at the state and federal level is because of the way Michigan is configured, there's this domino effect that can occur, right? You start changing something in one area, and then there's a negative effect downstream with Medicaid cuts. And in Michigan, if those cuts were to occur, we didn't have the money to make up for it. We have a lot of people with severe mental illness that are supported in the community that without those supports may have nowhere to go. And I'm not saying that to scare people, but I think it's a reality that troubles me and causes me to advocate much harder, so that these cuts don't occur because of the devastation, which, with most policy change, it happens at the 50,000-foot level, but eventually it gets down to the human level. And then it's a scrambling of, oh, well, what do we do about the problem we just created? You know?
I encourage you, as part of my call to action, to, get those stories and of individuals, put a name, a city, a face if possible, and get that up to the congressional staff and say these are the people who are benefiting right now, and the problems that you'll create in the state are that these people may very well experience homelessness and criminalization and other really, really costly, disruptive, and traumatic even scenarios.
Absolutely. We have a question. What would the ramification of these cuts be on crisis services?
So I know Medicaid covers some crisis services, but not a ton. I think what it would do is really strain the crisis system and end up, more people would be calling 988, dumping into emergency departments, which are not equipped to really handle crises, filling up state hospitals. And I think, unfortunately, as I mentioned, that there would be more of a justice-focused way to try to address mental health and substance use through criminalization rather than through supportive services.
Yeah. Thanks for that, Karen, because the other thing that
The-
occurs to me is that some of these more specialized services that we've grown accustomed to don't necessarily have to be funded because they're not necessarily part of the Medicaid state plan. So I don't know where crisis services fall in that, but it could be you end up with just a very small number of essential services and that's it, which would exacerbate the situation.
Yes, and I know that the mental health block grant has a crisis set aside at 5%, so that funding would
Okay.
still be available. Thankfully, in the whole restructuring of HHS, the mental health block grant continues at its current
Okay.
authorization level. So we're really happy to see that. Um, and so that funding would remain, but it would place more, kind of burden on those grant dollars to help a larger, broader set of people who may be uninsured or otherwise um, unable to receive services. And and so the state will have to figure out, where it's going to cut since states have to have a balanced budget.
Yeah. Yeah. Speaking of United States Department of Health and Human Services, I know I looked at the document, the proposed budget, the document that was leaked back in April, and it talks about eliminating funding for certified community behavioral health clinics or CCBHCs, and it talks about eliminating SAMHSA. Do you have any updates on where that is currently?
Unfortunately, we really don't. Um,
Okay.
but we do have some good news in that while the agency has proposed a very skinny budget that eliminates a ton of behavioral health programs, both for services, workforce training and development, and for, um, kind of wraparound services, we have seen congressional appropriators say that that's not their guiding document. They're not going to be passing the federal appropriations bills based on that budget. They're going to go a different route. They certainly will not be cutting all those programs. However, we do not yet have a bill from the appropriations committee that handles HHS. So once we have that
Okay.
draft legislation, which is being worked on, although, reconciliation is really the priority, the appropriations committee deadlines have pretty much passed. So all those requests members have already submitted to the committee, and the committee's staff will kind of package it together into one bill. And then we'll be able to determine, where we need to put a stake in and say, yes, keep this as is, and where we need to really push them to in a different direction. And we can kind of provide an update on that in the coming weeks. I'm
Okay.
actually not
Thank you.
sure though, as far as timing, the appropriations bill could come out in the next, few weeks if the House passes reconciliation, but it also could be, July or September even, just depends. It will not be a traditionally bipartisan process. Republicans are going to come up with what they want. Senator Collins in the Senate and Representative Cole in the House, those are the chairs of the appropriations committees. And I think Democrats will get some priorities in. I will say that fortunately, it seems that 988 is a very Republican-friendly policy, so it seems they will continue to fund 988. Maybe
Okay.
even get an increase. We were asking for 613 million, which is like a $75 million increase over FY25. We're also seeing that while mental health prevention is not at the top of their list, they do seem to still be working on some substance use prevention. So we expect that substance use prevention programs will continue to see funding. And I think we're trying to keep an eye on the mental health block grant. I think that's the top priority for MHA.
Thank you. So going back to what you said, you were explaining that this reconciliation process means that there will be a markup at, is it 1 o'clock in the morning tomorrow morning or Thursday morning? When is that?
Yes,
Tomorrow morning?
tomorrow. Well, Wednesday, 1 a.m. So in about 12 hours, I guess.
So in terms of advocacy, what do you recommend? You were talking about the importance of getting stories up to members of Congress. Is there anything else people could be doing to kind of help advocate that those
Yes.
reductions don't take place?
Yes, we have an action alert that went out last week, so folks can send a letter to their representatives. I think at this time, it's so critical, though, to really disrupt business as usual that I'm going to send out an email either later today or early tomorrow morning asking people to just call the Capitol switchboard and make calls to
Okay.
their members. And I have to say, I have called some member offices this year more than 15 times and have not once been able to reach anyone, but I leave a message every time.
Yep.
It's much better if you can get someone on the phone, but it's still impactful if you can leave a message, if you can make sure the lines are, really blowing up and that calls are coming in, because that lets the office know that you're paying attention and you're going to hold them accountable for their vote. And word is spreading. There are protests in California and in DC, all throughout the nation, really today and tomorrow, to protest these cuts. And I mean, if folks are willing to go out and march and demonstrate, that is always an option. MHA is not organizing a demonstration, but we're not against other folks doing it.
Does anybody have any questions about some of the things that Karen's been talking about today? We had a question in the chat. We had someone else raise their hand, but does anybody have any questions about anything? I know that for us, whenever something comes from Mental Health America, we send it out to anybody on our email list. So if you're not getting that information, please put your email in the chat so that we can send it to you, so that we can keep you apprised of what's going on. So Karen, what is the process? So they're going to mark this bill up at 1 o'clock tomorrow morning. Then what happens after
Once
that?
once the Rules Committee passes the rule for the bill, that will determine how much debate is allowed on each side of the aisle, the timing of the bill coming to the floor, and all of that. I believe that we would expect to see, or the speaker is planning to bring the bill to the floor sometime on Thursday. So
Okay.
that I can share, I believe I can. Ooh, do I have it here? Yes. The bill text that is most recent, that just came out today, is here. The you'll see in Title 4, Subtitle D, this this is the health section that has all of the Medicaid related provisions. And again, in order for a section to be part of this bill, it has to either raise revenue or spend revenue. So everything has to have a
Okay.
cost associated with it. And the Families USA section by section summary actually has the cost associated with it, with each provision in that document, that summary document. And those costs
Okay.
are estimated by the Congressional Budget Office, which is a nonpartisan office.
Okay.
So yes, I think that sending letters, making calls, and even requesting to meet with your congressional representatives is a good thing to do. You can meet with them virtually, the legislative staff in Washington, D.C., or you can ask for an in-person meeting with one of the district office staff. I mean, there are 15 people on this call. I think there are about 12 or 13 members of the Michigan delegation. Don't worry about the Democrats. They have no power. They can do absolutely nothing at this point. They have not been able to really, do the points of order or stop anything from happening. So really focusing your messaging, your time on the Republican members is most effective. Again, we don't think that the Michigan members will really be responsive and change their stance because they're pretty much falling in line with party leadership. However, that doesn't mean that they shouldn't hear from those in their districts. They need to hear the stories of how cuts will impact people. They need to know that there's a system in place that will really have gaps and issues. And the two talking points that they've been using is that they're cutting waste, fraud, and abuse. There's not one thing in the bill that helps CMS or states identify fraud, waste, and abuse, and investigate and then penalize bad actors for those activities. And their second argument that they've used is that, well, these expansion population people are, they're lazy, they're not working, and they need to at least try to work. And what we know is that work requirements are not an effective way to get people working. Recovery ready workplaces are, employment training, supported employment. These are things that help people with staying at work. Margaret?
Thank you.
Well, you actually answered my question. How do we, I guess it stuns me when my representative says that it's because of all the waste, fraud, and abuse that we have to cut this. And I know, I mean, I have to listen to, the stuff on HIPAA and waste, fraud, and abuse every year for my medical. But I don't know where they don't even have the statistics to say how much waste, fraud, and abuse is the cause. Do we have those stats?
No.
It's sort of like they're
Um,
saying it, and we do have, they talk about in these trainings that I have to do, but I don't remember the statistics, but it seems like they're
So
going after people for years of it, and that builds up.
if
there, I think it's just it's a scapegoat idea. And they've
Yeah.
also said that, having this expanded population utilize Medicaid and its resources takes away from the traditional Medicaid population, moms, people with disabilities, children.
Mhm.
And they've presented no evidence to that kind of resource. Uh, I don't know what to call it, but like they've provided no evidence to say that having these, new populations of adults on Medicaid actually is taking away from any care that anyone else would need. It's really just a false narrative that's being used.
Yeah, I want to add to that too. So in my previous life, I worked for the protection and advocacy in Michigan. This was years ago. And when it comes to fraud, waste, abuse on the Medicaid side, that's actually the federal government expects the states to conduct those investigations and monitor for fraud, waste, and abuse on the Medicaid side. And years ago, I actually conducted a fraud investigation regarding Medicaid, and it was a lot longer than a weekend looking at files. It was a lot of data gathering and a lot of information gathering before I turned it over to the Attorney General of the state of Michigan. So I agree with Karen. I think a lot of this is just a way of trying to say, well, we're not really hurting anybody. We're just going to make sure that people that are committing these crimes, whether, fraud, waste, and abuse, aren't able to do that anymore. But I don't think it's as prevalent as it's being alleged. And there's certainly an investigative process that is supposed to be followed before, those claims can be made. At least that's been my experience.
Yes, and please note that there are provisions in subtitle D, the health provisions of the budget reconciliation bill that say prevent wasteful spending and identify fraud. And that's really not what's kind of happening there, even though it's being framed as such in those provisions. For instance,
Thank
there's
you.
subpart B, preventing wasteful spending. And what they're doing in section 44122, modifying retroactive coverage under Medicare and CHIP, is saying that instead of covering someone who is, newly eligible or who is just enrolled and covering their services 3 months prior to their enrollment, they're only going to cover it up to 1 month prior to enrollment. So previously, it takes so long to get enrolled in Medicaid that if someone had some type of medical bills 3 months prior to their enrollment date, Medicaid would be retroactive back to that. That is not
Yeah.
wasteful spending.
No.
I mean, but it's being framed as such. So it's really important to know that they're being very intentional about framing and messaging. And it's very important that as advocates, we are just as intentional about what is waste and what is consumer, protections, what is helping families on the ground.
Yeah. So you're saying that, I mean, I know for years that you could go back 90 days once you became Medicaid eligible. They want to reduce that to 30 days now.
Correct. That is one of the provisions on the bill that is generating savings according to the Congressional Budget Office.
But that also means that people who have health conditions, like who needed acute care for a heart attack or something, and like you said, it takes a minute to get on the Medicaid rolls, they will not be able to get their outpatient or their care covered retroactively, which is really disturbing. And that's going to harm providers, especially hospitals, if that goes through.
Absolutely. The good news is that we're on the same side as the hospitals, so they're also fighting. The American Hospital Association is fighting these cuts. There are other hospitals, and the hospitals that will be most impacted are those in rural areas,
Yes.
which are already shutting down faster than other hospitals. So, as someone who recently relocated to Florida, I'm learning that sometimes women who are pregnant have to drive 2 or 3 hours to get to kind of, a birthing hospital. If that closes down, then the alternative really is to just be delivering at home or in a doctor's office. I mean, it's just really incredible, the kind of lack of concern that there really is right now. And you know, I learned in the last year or two that really mental health conditions and substance use disorders are the number one contributor to maternal mortality. So
Mm.
while I think, US has the highest maternal mortality rate of any country that's developed, and while most of the provisions in the budget reconciliation kind of protect the traditional mother children enrollees, some of the provisions do not. There's you know a rule under the Biden administration that would have made it easier for if a child was on CHIP and they needed to, move to a different plan or something like that, they would easily be able to kind of move through plans without the mother having to provide additional documentation for the child, and that they're just putting a moratorium on implementation of those rules.
Thank you for that. Thank you for that, Karen. I'm watching the time here. Does anybody have any questions for Karen?
I will also say that because Michigan is not a state where we expect to see a ton of kind of changes in in voting for members. It's still important to outreach. But if you all have contacts, partners, collaborators across the states in the districts of Representative Siscomani in Arizona, Senator Murkowski in Alaska, Senator Curtis in Utah, Representative Malliotakis in New York, Representative Kane in New Jersey, in Representative Van Drew in New Jersey. If you have collaborators, partners, advocates, colleagues in those districts, that's where I would really encourage you to kind of push them to speak out and really reach out to the offices, because there's a list of moderates that have signed a letter to the speaker saying that they didn't want to cut Medicaid for vulnerable populations, and they're really those are our kind of last hope. I'll try to pull up that letter real quick with the list of Republicans. This is the Gonzalez Valadeo Congressional Hispanic Caucus letter.
Thank you.
And you'll see that it's signed by 12 members, and those are the ones that there's a little bit of hope for. Like, for instance, Representative David Valadeo from California, his district is more than 50% made of Medicaid recipients. So if they're all losing their coverage, he's not going to win election.
I'm glad that this was helpful for everybody. Karen, do we just want to touch briefly on parity? I had emailed you, and I
Sure.
appreciated this response from Tim. Just basically some concerns about some of the rules that were being changed, potentially that not happening. Can you just talk about that?
Absolutely. Just briefly, the Trump administration came out week before last and said they would not be defending the parity rule that the Biden administration finalized in September of 2024. The rule, we kind of expected that they may not defend that rule, and even though it was a rule implementing the parity amendment that Trump signed into law in 2018. So it's something that previously was okay for the administration and now is not. Uncertain what they will do at this point, if they'll rescind the rule, modify the rule, but in court they will no longer defend it. And what is more concerning, however, to MHA is that the administration came out to say that they want to evaluate and investigate all of parity enforcement oversight. While the enforcement program helped over the last 4 years to find 21 different types of parity violations, and I can share the chart with you here on pages. Ooh, that didn't come out right. I think that link will work. This report by the Department of Labor's Parity Enforcement Division shows that on page 19 and 20, health plans were in 21 different ways denying due coverage, from denying nutrition assistance for eating disorders and other care like this. The program has been successfully funded the last 4 years. And so we are concerned that if the administration is saying they want to evaluate and investigate this enforcement program, that means they're going to take away some of the authority and power that they've had to really penalize insurers for these violations. So we're hoping, though not holding our breath, that the investigation of the parity enforcement program will be one that is beneficial to consumers and not to health plans. But in the meantime, we're just kind of waiting to see what they end up doing. Well, just thank you for having me. I appreciate the comments and questions in the chat and on screen. I'm really grateful that you all are tuned in and ready to kind of take action at this point. The next 48 hours will be extremely, extremely important for the Speaker of the House and for Congress. Although I will say that there's a little bit of saving grace in the Senate. There seems to be much less of an appetite for Republican senators to cut Medicaid as far as the House bill does. So what we're thinking is most likely is the bill that is likely to pass the House this week would be modified in the Senate and then sent back to the House
Okay.
at some point with some smaller versions of cuts. But I don't think they're going to take out work requirements entirely, though, to be honest.
So what about this? The speaker wanted to have what done before Memorial Day? The House version of a bill ready to send over to the Senate? Is that what
Yes,
he wanted?
yes,
Okay.
that's what he's working toward.
Okay. So that means that there's still opportunity to advocate, because now then it's the Senate's
Absolutely.
turn to weigh in. Okay. Okay. So
Absolutely.
that's important to know. Thank you.
Absolutely.
Thank you very much.
And the senators that we think are most likely to be attuned to public views are Murkowski in Alaska, Hawley in Missouri, Curtis in Utah, and Collins in Maine. We think those. So if you have connections in those states, please do as much as you can to push them.
Okay. Well, thank you.
Thank you.
Well, Karen, thank you for joining us today. And I want to thank everybody else that joined us for this webinar today. I'm glad it was helpful. And I really appreciate the partnership that we have with Mental Health America. They give us a lot of great information about what's going on at the national level. And Karen's really helpful in helping me know how to write emails to members of Congress about these issues. So I appreciate her very much. So with that, I'm gonna have us sign off now. But again, I hope y'all have a great day and keep up the advocacy. It's super important. Have a good rest of your day.
Thank you.
Thank you.